Good afternoon, good morning, wherever you are. I'm Dr. Renee Matthews. I'm a board member with the Chicago Asthma Consortium. In today's schedule, we will just have an overview and I'll introduce our speaker, Dr. Thomas Ritz, and then he will speak from 12:05 to 12:20, and then we will have Q&A 12:20 to 12:30. So feel free to put questions in the chat at any time, and then when we come to the Q&A section, we will then address those questions, and we should be done by 12:30. Just a little bit of housekeeping. Attendees, video and audio should be off during the first half of the webinar and the closing of the webinar. Anyone with technical difficulties, please contact Kay via the chat feature or by email at info@chicagoasthma.org. Networking and communications. Use the chat feature to introduce yourself. Say hello to other attendees. Any questions for the presenter, type your questions in the chat and our presenters will answer them during the Q&A session at the end of the presentation. There also will be a webinar evaluation that will appear in the chat. Please share your thoughts about today's presentation with us afterwards. The evaluation link will be posted in the chat feature at the end of the event. Thank you. So a little bit about the Chicago Asthma Consortium. Our mission is to seek to improve quality of life for those with asthma through advocacy, education, and collaboration. The purpose is to bring together medical and public health professionals, business leaders, government agencies, community-based organizations, and individuals dedicated to raising awareness of asthma and improving quality of life for those living with asthma. Help us make an impact. Learn more about how you can become a member and contribute. You can join us at www.chicagoasthma.org. And there's other ways you can help. You can volunteer with a committee. We have several committees: the Community Advisory Board, Community Engagement, Fundraising, Membership, Professional Development, and Schools. Or you could join the board. We are accepting applications now. Contact info@chicagoasthma.org for more information. Hold on. Dr. Thomas Ritz received his PhD from the University of Hamburg, Germany, and worked as a postdoctoral fellow at the University of London, St. George's Hospital Medical School, and Stanford University Medical School, and the VA Palo Alto. Following his habilitation and receipt of the Venia Legendi in Germany, he joined the Department of Psychology at Southern Methodist University in Dallas, Texas in 2005. His research of the past 30+ years has focused on the psychobiology and psychosomatic medicine of respiratory disease and comorbid affective disorders. Much of his work is interdisciplinary with colleagues in biology, chemistry, and medicine, with an emphasis on consolidating a basic research foundation for asthma management and translating basic findings into psychological, behavioral, and lifestyle interventions for asthma and comorbid psychological disorders. In ongoing research, he studies the role of the central nervous system in asthma, the prevention of stress-induced respiratory infections, and the biologically informed treatments for anxiety and anhedonia. His research has been supported by federal funding agencies and private foundations in the US, Germany, Canada, and the UK. He is a fellow of the American Psychosomatic Society and currently editor for the journal Biological Psychology. Dr. Ritz?
Yes, thank you, Renee, for the introduction, and thank you, everyone, for having me here. I'm trying to...
Go ahead. You should be able to now. I'm sorry.
Share my screen now. Can you see the presentation?
Yes, perfect.
Okay. Well, I'm going to talk about a topic that has probably accompanied me for the past 30 years plus, and that's really about emotion, stress, mood, and how it might affect asthma. And I have prepared quite a bit of material, so I hope we'll get through it. But just to kick it off, I like to think about emotions and stress and asthma as the phantom triggers. So we don't really know a lot about it. Is it really there? How can we see it? Does it make a difference in asthma? I think opinions vary. And that's what we try to address in ongoing research and have addressed in past research. And also others have contributed to that. It's not just our own work in that area. And when we look at the guidelines, the asthma guidelines, as you may have realized, emotions and stress are actually accepted as triggers of asthma. And that has already started in 2007 with the NIH supported guidelines, NHLBI, that cite under precipitating and aggravating factors emotions and stress. So emotions like fear, anger, frustration, crying, stress, fear, anger, frustration, and so on. So that's pretty established, apparently. And we can also look at the other end of the world in Japan. Guidelines here, for example, show you an even deeper appreciation of emotions, psychosomatic and social factors in asthma. Social stress affects the development, exacerbation, and management of asthma. Associations between panic disorder and emergency room visits have been reported, and so on. It goes on and on about psychosomatic factors in asthma. When we ask patients, and that's probably the first thing that we want to do, what their experience is, they report pretty consistently, 15 to 25% of them, that psychological triggers play a role in their asthma and that they are associated with clinical outcomes. We have investigated that with questionnaires, surveys, psychometrically evaluated questionnaire material that has shown pretty consistently across countries, actually, Germany, UK, US. We even have had data from Indonesia in one study, and here shown actually from Peru compared to New York. New Yorker Puerto Rican public population, that pretty consistently around 20, 25, 30% of patients report that emotions and stress play a role. And that actually also affects asthma outcomes or is associated with asthma outcomes. And we can see if we try to predict asthma control, exacerbations, emergency treatments, that psychological triggers actually double the chance of playing a role in these events. And also, you have double the odds of having lower asthma control when you have psychological factors as a trigger when you experience that. And this is even controlling for psychopathology like anxiety and depression, and controlling for other trigger factors. Other trigger factors also play a role, but it's pretty solid actually for psychological triggers. So what's going on? Do they really affect asthma in a visible way? Well, they actually lead to bronchoconstriction. That's what has been found for quite some time, and that can unfold through multiple pathways. And probably the pathways that are most commonly looked at are autonomic one, or autonomic nervous system, and that's the smooth muscle regulation of the airways. The airways constrict in a certain excitation, autonomic excitation. These are immediate short-lived effects. And then, of course, we have influences of psychological factors on immune processes, on inflammation, which may exert more longer-lasting and delayed effects. So for the first pathway, we have action on the airway smooth muscles. Bronchoconstriction, airway obstruction are an immediate outcome of autonomic regulation. This is a bit more complicated. view of a number of factors that could act on the airway smooth muscles. With a vagal parasympathetic excitation, you have a constriction of the airway smooth muscle of bronchoconstriction, whereas sympathetic effects actually lead to a bronchodilation. And these are your bronchodilator effects, of course, the beta-adrenergic bronchodilators. We also have effects of ventilation, of breathing patterns on the airway smooth muscle, and in particular, hyperventilation plays a role here. Hypocapnia constricts the airway smooth muscles. Deep inflations, deep lung inflations can, at least if you don't have severe asthma, can also dilate the airways. When we talk about stress and asthma, is actually a pretty curious situation, because you would think that stress effects actually help asthma. And that's because stress elicits sympathetic excitation. That should lead to bronchodilation, similar to medication, to the bronchodilators we have. It also has been shown to reduce parasympathetic tone, which again should lead to bronchodilation. And then we have other stress hormones like cortisol, which should actually exert anti-inflammatory effects. So, and then we have maybe muscle activity, tensing your muscles, also a bronchodilator. So how can it happen that in asthma we have these bronchoconstrictions? That's a great enigma, and we're right now just scratching the surface of what is going on. In the laboratory, we typically explore these effects with a number of paradigms. So an older paradigm, which has been used a lot in the past, are suggestions that suggest patients, for example, that they inhale a bronchoconstrictive substance and see what happens to the airways. We have ways of inducing emotions in the laboratory under controlled conditions. We can use pictures, movie scenes, imagery, and so on. And stress induction, of course. We can provide people with mental arithmetic tasks and other cognitive tasks, speech, free speech, stress interviews, and so on. So we have ways of studying directly what happens to the airways. Now, these laboratory studies have demonstrated that probably 20 to 40% of asthma patients show clinically significant bronchoconstriction to specific suggestions. And this is old research that has already been started in the 1960s that has shown that a good proportion of patients with asthma are suggestive in terms of their lung function. So they may have lung function declines, here shown in terms of airway conductance, lung function declines when they are presented in that case, bogus intravenous allergen. Something that actually is saline, but is presented as an allergen. So they have reductions in lung function. When you then present them with a placebo bronchodilator, they will show improvements in lung function. That is an old established effect, and a review of that literature shows that at least 20% of patients show such responses, and that the likely origin of these are vagal excitations, so parasympathetic excitations, a cholinergic pathway that is somehow activated in these patients. Now, to the laboratory studies that have used emotion induction, again, we find bronchoconstriction in a number of patients. And actually, that bronchoconstriction that we see in the laboratory is associated with what patients report in terms of their asthma triggers. So this is just here a slide that shows you the many studies that have been done in that area. We're not the only ones. We have used particular paradigms, but others have worked on that before, already starting in the 1970s. So this is one study we undertook, and we showed patients various pre-film clips, movie scenes of 2 to 5 minutes, and we measured their respiratory resistance. So which is a worsening of lung function in that case if it's higher. What we find is that in asthma patients, first of all, you see stronger constriction throughout, but then you see that during any emotional stimulation, whether it's elation, happiness, contentment, depression, and so on, compared to neutral, you have an elevation of the airway constriction. This is measured continuously with forced oscillation, and that's the best technique to really measure throughout stimulation. We see a similar pattern, actually, interestingly, in healthy participants, and that tells us something about the general reactivity of the airways to such stimuli. This has also been confirmed in body plethysmography, whole body plethysmography, the gold standard of lung function measurements from a good colleague from Hamburg. And you see here on the asthmatic side of the slides, you see how during negative, unpleasant, neutral, and pleasant stimuli, you see these elevated levels of airway resistance, but you have greater elevations during the emotional stimuli. Now, the one stimulus that we observed is particularly potent in leading to constrictions is about blood injuries and injections. So this type of stimulus, which is probably also, so evidence supports that this is linked to a vagal excitation, that this actually constricts the airways the most. And you see here in asthma patients how watching a surgery movie leads to elevated airway constriction compared to neutral and other unpleasant stimuli. You see a similar pattern also on a lower level with healthy controls. Now, the interesting part and why this is not just academic ivory tower research shows, and we have replicated that in 4 studies now, that these responses to emotional film clips in the laboratory are associated to the trigger reports of asthma patients, that asthma patients report in their daily life that psychological triggers play a role. They also show stronger constrictions. We have shown that this is a vagal mechanism as well. We used ipratropium bromide, a anticholinergic medication, an inhaler, to block vagal airway constriction, and that really reduces the response of asthma patients to these negative stimuli. It's also not related to non-specific airway hyperreactivity under placebo conditions and airway inflammation. So we assume that is really a central vagal excitation that takes place in during these stimuli. Well, other stress studies, let me add that. Other stress studies have shown a mixed effects, actually. So these were basically trying to induce pure emotions, whereas here we're looking at stress tasks that I had shown you, mental arithmetic and so on. Here we find a mixed pattern, and this is a review of another team, and they find that so passive stresses that you have to endure and where you just can't do anything about it, these seem to constrict the airways pretty much like these emotional stimuli did. But stresses where you have to become active, where you have to be really coping with the situation actively, they don't show that particular constriction, vagal constriction. So that may actually be due to the additional sympathetic dilation, although this hasn't been shown very consistently so far. Well, adding to that, we have observational studies over longer time periods. And here is one that shows that actually, when you observe asthma attacks, which are defined by exacerbations of peak flow and symptom increase over days, that after major life events, negative life events, probably 1 or 2 days after that, you pretty consistently find exacerbations in children. We found that in the field, when we observe the changes in lung function, or when patients have diaries with their lung function measurements, that these declines in negative episodes, negative mood episodes, are actually linked to the laboratory-induced emotional bronchoconstrictions that we can see. So again, we're observing a phenomenon that is real and that affects lung function. Coming to longer lasting stress, well, this has an effect of exacerbating airway inflammation and thereby asthma. And this is a classical study that has demonstrated that for students that undergo final examinations, stress levels that they have, they combined these periods with allergen testing. So inhaling allergens, and I think it was dust mite allergens, but I'm not 100% sure now. But what they see is that in periods of examination stress, when they perform these allergen challenges, they see a relatively consistent increase after 6, but in particular after 24 hours in airway eosinophils. And that increase in airway eosinophils is related to lower lung function, as we can see here now. So other studies, including ours, have shown that stress over longer periods of time observed increases airway inflammation and thereby also decreases lung function. So that as a mediator is by now probably well established. Now, what is going on? Why does it increase inflammation, and particularly in asthma? What we found actually is, and what others have observed as well, is that endogenous cortisol, so the stress hormone cortisol that actually has anti-inflammatory effects, is lower in asthma. So that we could think is maybe a medication effect. We have a downregulation of the whole system through the medication, but studies have shown that it's even if you control for medication intake, you still find that effect. And we found it here in the cortisol response upon awakening. So that's the morning cortisol mobilization that happens, and that is particularly relevant when you have stressful, challenging days. And that particular mobilization is weaker, significantly weaker in asthma patients. And that is actually related to a indicator of airway inflammation, the exhaled nitric oxide, as we have found. So a potential pathway how inflammation is actually exacerbated by the lack of anti-inflammatory response that you typically get from stress hormones, in particular cortisol in asthma. So also long-term psychological stress has been shown as a risk factor. I wanted to add that. So adverse childhood experiences have been shown to elevate actually the chance of onset of asthma, so development of asthma, not necessarily just exacerbating it, but also developing asthma. And again, in these studies, we typically find an under-responsiveness of the HPA axis, meaning less cortisol secreted upon challenge. So there may be a hormonal endocrine pathway that plays a role here. So how does it fit all together? Well, we already have a pretty complex model that shows that emotion and stress act directly on physiological mediators, direct mediators of inflammation and bronchoconstriction, and thereby affect asthma control. So these are the effects that we have observed and where we have evidence that it happens. But then when you look at the whole picture, it gets even more complicated. You also have to factor in the indirect mediators, health behaviors, disease management also play a role here. And of course, genes and environment interacting with the central nervous system. So it's a complex picture, and but it's one that a scientist finds especially interesting and challenging, and helps scientists to persevere with that topic. So many ways lead to Rome, only two pathways three pathways here shown, actually, that we have talked about. I haven't talked a lot about ventilation, ventilatory pathways, hyperventilation, but that may also affect the lung function. And you see that airway constriction takes different trajectories depending on which pathway is activated. You could have an immediate effect within minutes, and then a delayed effect when you maybe hyperventilate. The inflammatory pathway could develop across days, and patients would not necessarily be able to make it to associate their stress with changes in asthma. It's easier for them to associate that when they have the immediate effect of exposure to a very emotional event and then feel the bronchoconstriction, like in the autonomic pathway. So we have quite a bit of a variety in pathways that could lead to bronchoconstriction, airway constriction, and the chance of patients to realize that this is actually what happens. And that's what makes that trigger the emotions and the stress so difficult to pin down. We also have to keep in mind that there's variation in how patients respond. We have heard about the 20 to 40%, and you can see that here in patients when they are exposed to these film clips, to the surgery film clips. You see here one patient who is very responsive. The other one doesn't respond much more to it than to a normal negative stimulus, although responses are greater than you find to a negative and neutral film clip. So there's quite a bit of individual variability, and we haven't even started to explore how this is related to the typical phenotypes and endotypes that are being discussed for asthma at the moment. And this is one of the future challenges that we have. There are particular vulnerabilities in patients, and there are coping strategies, differences in coping strategies and resilience that patients can bring to the table. And that will all hopefully at one point lead us to a more personalized application of treatment suggestions. Just a final summary of the takeaway messages. Patients report psychological triggers up to 30%. Psychological triggers are associated with low asthma control, exacerbations, and ER visits. It doubles the chance that you have problems with these if you have psychological triggers. Clinically relevant airway obstruction to emotion in the laboratory, 20 to 40%. Psychological triggers are associated with airway obstruction to emotion in the laboratory. You have approximately 20% shared variance here. In daily life, 25% of patients are probably responsive. Negative life events lead to exacerbations 1 to 2 days later. In children, shown to be up to five times the risk, and adverse childhood experiences also have an elevated risk of leading to later asthma development. Okay, that was a lot of material. Thank you for your attention, and I welcome questions. And if we don't get to questions right now, I can also answer them by email if needed. Thank you.
Thank you, Dr. Ritz. Tom, I don't see any questions in the chat, but
Okay.
so we might just anyone have any questions? Now's the time. Okay, well, I guess maybe we'll get out early today. So please check our website for any upcoming events we have. You can find more information at www.chicagoasthma.org/events. And you can check that for the Fall Lunch and Learn series and our conference. Remember, the evaluation is going to be in the chat, so please make sure you click on that survey link in the chat. We'll stay here a little bit so that you have a chance to get that. Other questions, email our association manager at info@chicagoasthma.org, info@chicagoasthma.org. Thank you so much for attending today.
Well, thank you so much for having me. I saw there's one question, but I'm not sure we have time for it. Or actually more questions.
Oh, wait a minute. Hold on. I have 2 middle school students who fit in with this information, adding some of the slides to my walls to show students and parents. Oh, wonderful.
Absolutely. Let me know if you want more information or materials.
Someone else said great information. When my kids would end up in the hospital with pneumonia, my asthma would also flare due to the stress and strong emotions. Makes perfect sense.
Yeah. Yeah. So these are common observations that we have. And there are apparently physiological pathways that can explain these responses.
Yeah. Okay, thank you so much, everyone.
Thank you for having me. Thank you for everyone.